On to you, Dr. Partha. Your attack is look forward to.
Thank you, Chitra. Thank you very much, Chitra and the ARC for giving this opportunity to say that LRIs do not help for refractive accuracy in low grades of astigmatism. Cataract surgery is the new cataract refractive surgery, and I think both of us agree to it. If we agree to this, then we also need to agree that femtolaser, the premium IOLs, and astigmatic correction remains the holy grail, but no LRI. Shortcut methods to maybe please the patient temporarily, I don't think is something that we require. Why I never prefer LRI over the toric IOL? Well, the tissue response cannot be titrated. There can be undercorrection, overcorrection, new axis of a cylinder might come up, and the astigmatism might become irregular. Sir showed the diamond knife manual LRI. Even if it is the flax-assisted LRI, there is a possibility of error, and all these errors can keep happening, more so with the diamond knife. How much to incise? So many nomograms are available on the net, but no one knows it full well. And not a single one is verified. It becomes more of an art than a science, and the artistry of Dr. Suhas Haldipurkar cannot be emulated by every cataract surgeon. This is important. There is a risk to infection, and this is an unnecessary risk. And in our experience, we have published this paper in the IGO, and where we saw that there was an infection in the LRI, and therefore LRIs are not 100% safe at all. Persistent epithelial defect can occur, and a post-operative dry eye is very much strongly there. But the most important factor is the regression. Would you like to offer a temporary solution to the patient? Do they know what procedure that you're going to do, and are they going to trust that procedure, even if it is with a diamond knife or a flax LRI? The Cochrane Library, the meta-analysis, has this to say. And toric IOLs probably provide a higher chance of achieving astigmatism within 0.5 diopters after cataract surgery than compared to the LRI. And LRIs can still be qualitatively viable, mean in those cases where toric IOLs are contraindicated. But otherwise, it is a toric IOL which is required. So is LRI a useful tool in itself if astigmatism is not too high, provided cornea is healthy, needs more accurate nomogram for calculation, but it's not accurate, however, may regress over time, may lead to infections? And would you like to offer an imperfect technology with so many ifs and buts if you are not in that grade of artistry as Dr. Suhas Haldipurkar? My Guruji, who taught me capsular access in my early days of cataract surgery. But let us be honest. Thank you very
much. Thanks, Partha. That was a great talk. We know we are all challenged by the wound healing response and the regressions which occur with LRIs or with femto laser archway keratotomies, and torics do reign best. But having said that, I wanted to ask you, Partha, supposing you have a patient who wants a multifocal IOL, cannot afford the LRCS platform and the arcuates, and you don't do the LRIs, and he has a 1 diopter of with the rule astigmatism or 0.575 sil of against the rule, what would you do for him?
So
You
here
don't seem
again,
to like aquates either. I saw that thing you're showing. Would you be using aquate keratotomy at least?
yeah. So here we have your situation is one in which the patient wants a multifocal IOL. Now, with a multifocal IOL, the patient is already in that category that he's demanding, and he wishes to have something that is going to give him very accurate vision. So here again, an LRI will not be the ideal thing at all. It has to be a toric multifocal if you have to get this patient well corrected, very well corrected.
No, that in that you don't get toric IOL in the low astigmatism, which I mentioned to you.
Point 0.5, 0.75 is not required. Within one diopters, you can do a toric. We can do a multifocal or a trifocal IOL
Uh, I would want to
without LRI. Without
expert,
LRI.
expert panel. Dr. Ramurthy, are you there?
Yeah, I mean, I was using limb relaxing incisions, gave it up, and then picked it up again once I got the Varion. I mean, you already published about the results with toric IOLs, but the Varion, one of the major advantages I find is the accuracy with which we are able to place the incisions with a 600 micron guarded knife. And the Varion itself gives the incision size, the arc length of the incision that you need to make. Definitely, it's out of the question if it's more than 1.525 diopters against the rule of 0.75 diopters against the rule of 1.25 diopters with the rule. It will be a toric intraocular lens. These for the lesser amounts of astigmatism where you want to actually debulk the amount of astigmatism, especially with the multifocal intraocular lens. Is different. We are not talking about refractive accuracy, but talking about the reducing the amount of astigmatism these patients have to deal with. I think Suhas mentioned about the variability of the outcomes. One important point he did not mention is the corneal hysteresis. That's the reason it works well in older patients, while in the softer corneas, younger patients, LI results are somewhat less. That's why it works something like radial keratotomy. But whenever I'm dealing with small amounts of astigmatism, toric intraocular lens is not a choice, especially with multifocal intraocular lenses. I think it's an inexpensive way of debulking the astigmatism.
And before Harshul goes on to our next team, one last question. If you're going to be doing astigmatic keratotomy on a LRCS platform, would you prefer to do paired or unpaired arcs if the arc is falling on the site of the incision?
Okay, can I take that?
Yes.
Okay, the first thing that I'll wish to say is that not enough work has gone on in the LSCRS platform till recent past as regards the LRI, the placement, and the nomograms that have to be used. The COS 6 platform, which is there, which actually gives you the marking of the steeper axis on its own. That means that if you have it with a Cassini, it will be seen in the OPD and then it translates. And now the Donald field nomogram is there where you can alter it accordingly. So a single incision can be done on the opposite side of the incision where you are making the incision, or you can do a paired. So it all depends on the amount of astigmatism. Normally a single incision would be enough, because if you have an astigmatism, as Dr. Ram said, of more than 1.5 or 1.25, you will go in for a toric intraocular lens. But I 110% agree with what Ram said, that there is always a debulking of the astigmatism. The results are good. Our cyclotorsion compensation was not being done in the LRCS platforms earlier. Now, if you have a cyclotorsion compensation, you have an in vivo real-time depth perception that is there, which the OCT gives you, and therefore the results are good. And now there are pre-built Donald field nomograms which are there in the software of the version 6, which is there. So I'm sure as we do more studies.
4 o'clock.
Sorry?
No, it's okay.
So it is going to actually improve the outcomes which you have with the LRI. And the second thing is that we are rather apologetic about the possibility of a regression. Even if there is a regression, there is nothing stopping you to go back again and open up the incision, which can be opened, or to create another incision, which can be done subsequently. So LRI, I think, is a very useful armamentarium that all of us should have in our surgical armamentarium. And if you have an LSCRS, I would always do an LRI if I am not using a toric implant. And single is something that I normally prefer. If I have to do bi-arcuate and it is going to intersect with the incision, then I would rather move my incision to the temporal and keep the LSCRS as the bi-arcuate on the steeper axis where I want.
If I may just add on, sorry, if I may just add on, the important thing for all keratotomies is that you have to have 90% depth of your diamond knife. So you have to be sure that your diamond knife is titrated exactly to what you want. That is the important thing. That beyond that, nothing much else. The second thing is I would strongly suggest you look into the papers regarding what we call as lamellating keratotomy, where the incision is made at a 45-degree angle. It heals faster, does not induce problems, and regression is much less.
I think just a small point. I mean, Chitra, I think your question was whether if you have against the rule astigmatism, whether you will use a single arc or a paired arc, because usually we are doing clear corneal temporal phaco or LRCS, and the incisions temporally will be right in the axis where we are making the incision. So initially we are doing a single arc nasally, but nowadays we have routinely started doing paired arcs even in these situations, and it's usually at 8 millimeters, and then we are able to make incision temporally, avoiding intersecting with these laser arcuate keratotomies. So I am able to, most often we are facing against the rule astigmatism in this age group. So I often combine temporal clear corneal incision with a paired arcuate incisions, even in the against the rule astigmatism.
So what Ram is saying, you think that the intersection should not happen. So you have to move either of the two. So obviously what you would...
Maipal, what I'm trying to say is, I make my incisions even when I'm using the LRCS platform. I make the incisions with the diamond knife. So I make laser arcuate keratotomies, don't open them up, but I go temporarily only. But my incision avoids going through the arcuate keratotomy that has been created. And I find that it works well. And at the end of the surgery, I open up these arcuate keratotomies.
That's what you are. And one more thing that I've observed with the recent software is that they are also giving you the toric marking. I think those of you who have used this thing, you can get 2 lines marked on the cornea. And in 2 of our cases, these toric alignment markers and the incision were right on each other. So it kind of opened up. So what I am therefore doing is that I would wish to move the incision slightly off, or what I am doing is that I am doing these markings only at 10% depth. That means that I am leaving from below about 50% and from top about 40%. So there is the intrastromal only 10% of the mark, and you can still see those marks without actually having the problem of intersection. It's not for LRI, but it's for the toric marker that you can now get on the Catalyst system.
He's talking about the Cassini upgrade with the
Cassini upgrade with the toric alignment marker. Because they come like this, and when you're going the incision in 2 pieces, that is opened.
Shall we go on with our next team? Great speakers and great thoughts brought up. We could have had more questions. We'll keep